Morning, everyone. My name is Wael Mohammed, and I'm a third-year internal medicine resident at University of Missouri, Kansas City. Nice to meet you all. And I'd like to thank ACG for offering us this opportunity to present our, this study. So today I'm going to talk to you about our presentation. It's mainly an EUS. We are comparing EUS guided fine needle aspiration versus the fine or core needle biopsy for diagnostic yield and tissue sampling adequacy for molecular testing in patients with pancreatic ductal adenocarcinoma. So just a quick introduction. As you know, pancreatic ductal adenocarcinoma is the third most common cause of cancer death in the US, with a 5-year survival rate of around 9%. EUS has become the mainstay of diagnosis of pancreatic cancer, with tissue acquisition either through the fine needle aspiration, FNA, fine needle biopsy, FNB, or core needle biopsy, CNB. The standard method to obtain tissue material for biopsy and diagnosis has shifted from open techniques to minimally invasive techniques using EUS guidance. And at the moment, there is limited literature on the adequacy of sampling for molecular testing obtained via FNA versus FNB or CNB, and our study is aiming at comparing these two modalities regarding the sample adequacy for genomic sequencing. So a retrospective chart review study was conducted among all patients who underwent EUS for pancreatic ductal adenocarcinoma at our institution, St. Luke's Hospital, Kansas City, Missouri, and this was between January 1st, 2018, all the way up to December 31st, 2021. And patients were stratified based on the mode of tissue acquisition. So we had a group of FNA, fine needle aspiration, versus the FNB, CNB group. Then age, gender, tumor size and location, needle gauge size, number of passes, CA19-9 and CEA levels were recorded. A rapid on-site evaluation ROSE was performed in all cases by the cytotechnologist, and this was done at the endoscopy theater. Slides review of FNAs and FNBs was performed by a board-certified cytopathologist for the final pathological diagnosis, tumor surface area, tumor cellularity, and specimen adequacy for molecular testing. Here is a simplified illustration for the process of specimen processing. So you can see that once you get the specimen through EUS, it's going to be, this is the FNA, it's going to be in the form of a cytology smear, and usually it's rich in liquid material, and then this is going to be thin prepped in the form of like a cell block, and then finally it's going to be histopathologically examined. On the other side, for the FNB or CNB group, it's usually a core biopsy solid material, and this is like, will be forming a tissue block rather than a cell block, and then finally this block will be examined by the pathologist. We manually obtain baseline data, including demographics, EUS reports procedure details as documented by the endoscopist, including location, needle gauge size, number of passes, and pathology final diagnosis, in addition to genomic testing results through EMR chart review. Both cell blocks and FNBs were subsequently fixed in 10% neutral buffer formalin and embedded in paraffin to generate formalin-fixed paraffin-embedded blocks. And here's a couple of pathology slides representing the fine needle biopsy samples showing adequate amount of tissue material with abundant tumor cells suitable for molecular testing. For our results, we had a total of 132 patients who underwent EUS-guided biopsies. 76 of them were FNA, 48 were FNB, and 8 were combined. And 94.6% of the lesions were greater than 2 centimeters square in size. Around 56% involved the head of the pancreas. No post-procedure complications were reported in any of our patients. The most common site was the head and onset process in 28 lesions and 50 in the two groups. So 50 of them were the head of the pancreas, around like 28 in the head of pancreas, 50 in the onset process, And we noticed that the 22 gauge needle was the most used in around 32 of our patients, representing 58% in the CNB group, and 69 patients in the FNA group. The significant tumor characteristic was the tumor surface area with a median of 25 millimeters square for FNB versus 4 millimeters square for FNA, and this was statistically significant. For tumor cellularity, which was between 20% to 49% of cellularity. This was in 51% in the patients in the FNB group versus 39.5% in the FNA group. And then finally, the mean number of slides required was around 4.3 in the FNB group versus almost 5 in the FNA group. Adequate sample for molecular testing was obtained in 71.4% of our patients via CNB and 32.1% via FNA. And then for genomic testing, the obtained samples was performed in 46.4% in the CNB group and 23.8% in the FNA group. And both of them, for the sampling for molecular testing and genomic testing, this was statistically significant with a p-value of less than 0.001 and 0.005. On the other side, the mean number of passes wasn't statistically significant if comparing both groups together. And here we have this bar chart demonstrating the superiority of CNB, FNB group if compared to FNA group regarding the sample adequacy and genomic testing. In conclusion, although there was no significant difference in the number of passes needed to establish a diagnosis, we found that the EUS-guided FNB, CNB, under the guidance of rapid on-site specimen evaluation rows, demonstrated a higher value in obtaining adequate samples for molecular testing. Tumor surface area and tumor cellularity played a key role regardless of the type of tissue acquisition modality. And thank you so much for taking the time to listen to me today. Thank you.
Very well done, Mohammed. Very well done indeed. Just a quick question. The decision to go with core biopsies versus FNA, was that made a priori, or are you analyzing these in retrospect?
Yes, sir. So this was done actually. So we retrospectively reviewed all the charts, but what we saw over the past 4 years, our endoscopist, our intervention endoscopist, started using initially FNB. This was his mode of practice throughout the first couple of years. And then he shifted gradually to core needle biopsy in the upcoming 2 years after this. And we found that he had only eight patients who had who did the FNB and the CNB in the same patient from 2 different sides of the pancreas. But right now, his current mode of practice is just CNB, and he told us that the core needle biopsy now is the standard of treatment in most of the pancreatic adenocarcinoma patients.
Yes, I think I asked that question because there's a possibility that he's gotten better over time. And so the question was whether this is a real-time same condition analysis versus a sequential comparison. Mm-hmm. And that's important for us to understand, so that we can understand which is truly superior, as opposed to assuming that CNB is superior, for example.
Yeah, it was same time, Okay. That's a great question, for sure.
Good.
And then we have just time for one more question from the audience, but in the U.S., was a pathologist in attendance to judge the adequacy of the tissue with the biopsy, or does the CNB technique obviate the need for a pathologist?
Yes, sir. So what happens is that we always have the cytotechnologist who is going to be present inside the lab, and after the endoscopist will be removing, get the biopsy, he's going to handle it right away to the cytotechnologist who is going to use the rapid on-site examination to tell if the sample is adequate or not. But for the final pathological diagnosis, usually done by this certified pathologist in the lab, which is going to be a second step after the approval of the cytotechnologist on board right away. So it's a two-step technique.
Two-step.
Yeah.
Thank you very much.
Thank you, sir. Thank you all. You have a great one. Thank you, sir.
Okay, so our next presentation is entitled Autoimmune Pancreatitis Secondary to Immune Checkpoint Inhibitor Therapy, Type 3 AIP, Insights into a New Disease from Clinical Review and Serial Pancreatic Imaging. This will be presented by Dr. Thomas, and Dr. Thomas won an ACG Governor's Award for Excellence in Clinical Research. Welcome.